When we think about the start of a disease, we usually picture the day a doctor delivers the diagnosis. But for neurodegenerative conditions like Parkinson's, that moment on the calendar is an illusion. Today, the standard of care relies on subjective clinical motor exams. Neurologists watch a patient walk, test their reflexes, and look for visible tremors. Looking at this cross-section of the substantia nigra, the brain's dopamine production center, reveals the structural flaw in this approach. By the time that physical tremor is visible and a formal clinical diagnosis is made at year 0, the patient has already lost up to 70% of their dopamine-producing neurons. This irreversible cell death means the clinical diagnosis arrives years too late. We miss the critical therapeutic window, the period where neuroprotective drugs could theoretically halt the disease's progression before the damage is permanent. This hidden phase is known in neurology as the prodromal period. The disease is actively destroying tissue, but the external symptoms remain invisible to human observation. Relying on the human eye to spot Parkinson's ensures we stay behind the pathology. To actually stop the disease, medical science requires an objective method of measurement that works years before the first tremor. In March 2026, the medical journal Lancet Neurology published a study detailing a system capable of detecting Parkinson's with 89% accuracy, up to 7 years before clinical diagnosis. The data emerged from a massive 5-year longitudinal analysis tracking 50,000 individual participants. The continuous tracking framework driving this analysis was engineered by Verily, utilizing high-density sensor arrays to harvest physiological data. The clinical framework and the $50 million funding initiative behind the trials were driven by the Michael J. Fox Foundation, shifting their research focus toward objective digital biomarkers. Detecting a 7-year predictive lead time typically requires invasive procedures, spinal taps, radioactive DOT scans, or frequent laboratory blood work. This study used none of those. Instead, the researchers utilized artificial intelligence to analyze digital biomarkers. By replacing sporadic 30-minute clinical visits with passive continuous data capture, the algorithms effectively rewrote the diagnostic timeline. To understand how this works, we must look at what the algorithm is actually processing. The AI is not looking for Parkinson's disease. It is analyzing raw time series kinematics, the mathematical geometry of human movement. The primary inputs are derived from accelerometers and gyroscopes. These sensors capture spatial positioning at over 100 Hz, more than 100 times per second, mapping microscopic vibrations that are imperceptible to the patient. The hardware harvesting this high-frequency telemetry is the standard smartwatch already sitting on the patient's wrist. Secondary data streams come from everyday smartphone usage. The touchscreens measure keystroke dynamics, fractional changes in swipe velocity, and localized touch pressure anomalies that correlate with early motor stiffness. A tertiary stream utilizes the device's background microphones. On-device processing analyzes vocal prosody, scanning daily speech for the earliest indications of vocal cord microtremors. During a standard twice-a-year visit, a neurologist might observe a few hundred data points regarding a patient's physical state. Passive tracking through everyday consumer devices generates millions of distinct kinematic data points every single day, creating a continuous physiological map of the user. Collecting millions of data points creates a computational challenge. Standard machine learning models evaluate static moments in time, which makes them ineffective for analyzing the continuous fluidity of human movement over several months. A recurrent neural network retains memory of previous inputs, optimizing it for time series data. It filters out chaotic waveform spikes from daily activities, exposing a singular rhythmic frequency. Within this baseline, the AI scans for specific anomalies, like gait irregularities or REM sleep kinetic changes. This process involves calculating mathematical correlations between seemingly unrelated micromovements across a timeline of months. The RNN mathematically decodes the earliest physiological whispers of neurological decline, long before those signals are audible to a human. Moving from identifying a microscopic tremor to proving a 7-year predictive lead time requires a specific statistical evidence base. This scatterplot represents the Foundation study, tracking 50,000 participants across 5 years. Researchers tested the AI's early predictions against definitive endpoints. When the algorithm flagged a biomarker anomaly in year 1, they tracked if it matched a clinical diagnosis, confirmed by DAT scan years later. The results established a new benchmark. The longitudinal matches proved that the AI achieved an 89% sensitivity rate in identifying prodromal Parkinson's. Tech companies have spent years marketing consumer wearables with vague promises of health tracking and wellness prediction. The MJFF study established digital biomarkers as validated predictive medical science, replacing speculative tech claims with peer-reviewed evidence. This level of validation triggers rapid regulatory movement. Algorithms analyzing keystroke dynamics and gait have secured FDA breakthrough device designation, clearing the path for real-world clinical deployment. However, integrating this technology into everyday life creates a risk of misinterpretation. There is a danger that an alert from an AI screen will be mistaken for a definitive medical diagnosis. This funnel visualizes the medical reality. The AI is exclusively an algorithmic risk stratification tool. It sorts vast populations into risk categories, but a red flag is a mathematical probability, not a diagnostic confirmation. A positive algorithmic flag must trigger a human workflow. The digital alert flows directly into genetic counseling and clinical verification protocols, like targeted neuroimaging. If these risk assessment tools are deployed directly to consumers without this medical supervision, the inevitable false positives could overwhelm the healthcare system and inflict unnecessary trauma on healthy individuals. In this clinical workflow, AI functions as a high-sensitivity radar designed to alert the neurologist rather than act as a substitute. This early warning capability introduces a bioethical paradox. There is an immense psychological burden inherent in pre-symptomatic knowledge. Clinicians warn of the nocebo effect, the anxiety, behavioral changes, and depression, but can be induced simply by telling a patient they have a high probability of developing a neurodegenerative disease 7 years in the future. Additionally, researchers like Dr. Fei-Fei Li point out the critical need to address algorithmic bias. If the machine learning models are trained primarily on a single demographic dataset, they may fail to detect kinematic variations in others. Addressing these challenges is a clinical mandate. Equity in training data and robust mental health support systems must be built into the diagnostic pipeline before widespread rollout. Despite the ethical complexities, the global medical value of this technology is clear. This pathway represents the ultimate goal, finally unlocking the prodromal therapeutic window. By identifying patients with 89% accuracy years before the substantia nigra is destroyed, this early warning radar finally provides researchers with the specific cohort they need to test true disease-halting therapies. AI changes when we detect Parkinson's. Its greatest triumph is giving medical science the time it needs to finally stop it.